If my clock is correct, it is 9 o'clock. I wish to welcome all members, the Western Cape Health Department, and all guests. Welcome to the Standing Committee on Health on the 19th of August 2020 at 9 o'clock. Members, I wish to refer you to our rules of engagement. I am pretty sure that members are up to date with the procedure accordingly. I will then now ask all members to kindly switch off their videos and also to mute their microphones. Members, I also wish to advise you that the chat function on your right-hand side, in the absence of hand button, you may use the function to draw attention to the chair during these proceedings. I will now allow for members to introduce themselves as well as to the department in that order. Thank you, members. Please proceed.
Good morning, Chair, colleagues. Lorraine Botha.
Good morning, everyone. Rachel van Vogel.
Good morning, Deirdre Bartman from Scopa, a guest today.
Good morning, Chairperson Regan Allen.
Morning, Chairperson Lulama Mvimbi from the Standing Committee on Public Accounts. Thanks.
Good morning, Chairperson Melika Klavo for both Health and SCOPA.
Any other members present? Then the department may please proceed.
Good morning, Chairperson. I will introduce myself and I will ask the members of the Health Department to introduce themselves. I am Dr. Keith Kluti. I'm the Head of Department for the Department of Health. Thank you, Chairperson.
Chairperson, good morning. Simon Kay, Chief Financial Officer, Department of Health.
Chairperson, good morning. Dr. Karim, Sadiq Karim, Chief of Operations, Department of Health.
Good morning, Chairperson. Dr. Krish Vallabhji, Chief Director for Strategy, Department of Health. Thanks.
Good morning, Chair. Misha Kanzi, Risk Management Technical Support for the Department of Health. Thank you very much.
Does that cover all department representatives then? Any guests present this morning? No one. Thank you. Then we will proceed. Any apologies? None received from my side. I've just received a message for assistance to member bonds. If the ICT services can kindly attend to that. Colleagues, the purpose of the meeting is the briefing by the Department of Health on the progress made in addressing and mitigating the potential impact of the risks identified by the Audit Committee during the 2018-19 annual report. This meeting emanates from the 2018-19 annual report resolution of the Public Accounts Committee to the Standing Committee on Health to request a briefing from the Department of Health on this matter. The invitation for this meeting, thus, has been extended to members of the Standing Committee on Public Accounts to form part of this meeting. And we have heard in the welcoming address there are members present. Thank you so much. I will now ask the Department of Health to kindly proceed with the presentation, after which members we will then have an opportunity to pose questions. Can the department please proceed? Thank you.
Good morning, Chair. Good morning to the members, and also good morning to the department. Thank you for the opportunity And indeed, Chair, as you correctly stated, that this is the resolutions for the 2018-19. And the members probably might not recall if they were not here, but it's also the year when we received the first ever clean audit for the whole of the key controls in the department. And also it was about the mitigation related to when we have to implement it on the 2019-2020. So at this stage, 29, so the taste of the pudding is in the eating, meaning those mitigations will have applied it in that financial year of the 2019-2020, which is currently is still under the audit of the AG. So what I'm trying to highlight, Chair, is that our limitation is only to respond to those 2018-19 mitigation, which is 2 years ago, which is you won't be able to see whether we've applied it or not. So you'll rely on what you are saying, because you can only see it when we now, you call us to present after the auditing, the 2019-2020, then that's when we can be able to see the balance that did you apply this or not. So now it's gonna be just, this is what they said we should do, and this is what we have done. Where is the proof? Wait until the auditing of the 2019-2020. Thank you, Chair. Over to HOD. Then you can introduce your team, HOD.
Thank you, Minister Mbombo. Also, a warm welcome to you. I believe the introductions has been done, so I will then afford the department an opportunity. Thank you so much.
Thank you.
Thank you, Minister. Thank you, Chairperson, for the introduction. Chairperson, as the Minister rightfully says, myself and the entire team are here to answer the question, and we're sticking very strictly to the mandate for this presentation. So just to start off with an introductory comment, which I think is also our audit committee's experience, and what the audit committee then also articulated in their engagement with the Committee on Public Accounts. We have a very well-established strategic risk management process. It includes this formally appointed Departmental Risk Committee. It meets quarterly with clear risk champion, which is Dr. Vallabdi, Chief Director Strategy, which brings to our monthly TEXCO meeting any risk that needs to be escalated to our senior management. We also have risk owners for each of the strategic risks, and we then submit regular reports to the audit committee. And then, as stated, any risks above threshold, which is above moderate, are escalated and discussed at every senior management meeting in our department. So the purpose of this briefing is really to brief the Standing Committee on the strategic risk that was highlighted during 2018-19. Just to give you a sense, we're going to go to Q4, which is the last quarter. So that's the January to March 2019. That's the conclusion of the financial year 18-19. And what we do is we have the convention that a residual rating is either reduced or the residual rating increases. So it's a green arrow, or it's a green downward arrow, or it is a residual risk increases. That's an upward red arrow, or there's a residual rating that has changed, that remained unchanged from the preceding quarter, which is a sideways yellow arrow. So let's start with the risks. The first risk is budget constraints. So you can see the movement between Q3 and Q4 is that the inherent risk is extreme because the impact and the likelihood is 4 and 4, but the residual risk after our mitigation is low. Impact is 1, likelihood 2. So the tolerance is then within the tolerance level. It's low and within the tolerance level of the department. At the end of that financial year, the department actually underspent by 56 million at close of the financial year. The main reason for that underspending was the additional funds we received for filling of critical posts. And that was received in January of that year. The department has also well-developed financial controls, governance mechanisms, and monitoring systems. And we have a low level of control over service pressures driven by social determinants that fuel health expenditure. So overall, we have treated this risk, Chairperson, over the years as a very fundamental risk to the sustainability of our organization. And although we have these service pressures and escalating needs, we've always managed responsibly within the fiscal envelope that's provided to our department. It would be fair to say that the department has the potential to, if overspending, put the whole of Western Cape government at risk because of the size of the department. The second risk is the staff-related security incidents. The movement in residual risk from Q3 to Q4 for this one remained the same. The inherent risk is 4, which is impact 4, likelihood 4. The residual risk is high, with the impact being 2 and the likelihood 4. And the tolerance is above the level that, so this is one that we escalate to our senior management team, because this is something we have to do something about at senior management level. The inherent risk remains extreme, and the residual risk remains high due to the nature of the risk and the societal contributing factors that require multi-departmental interventions. And this is the violence, especially on the Cape Flats. Additional support was provided by the Department of Community Safety, so we worked very closely with DOCS in that time to the following facilities as a result of security threats. Now, you will remember that the quarters before, mainly our risk was associated with EMS and ambulance attacks. That was the main risk. For this specific quarter, we did additional things also for facilities where there were threats of violence to the facilities that find themselves in local communities. So the following, we had security threats, and which include protest action aimed at the facilities, and we worked with DOCS in those areas. That was the Gustero CDC in the Strand area, the False Bay Hospital, Khayelitsha Hospital, Helderberg Hospital, also Hout Bay, that was in the middle of quite tense relationships in the Hout Bay CDC, and then Nonzamo CDC, which was also quite tense at times in that time. They have also been engaging with the Mowbray Maternity Hospital, the Southern Western Substructure, the Khayelitsha Eastern Substructure, and the Northern Tygerberg Substructure line management on the security contract expansion request. So in that time, there were many contracts that we had to, at the multiple facilities across the Cape Flats, that we had to pay attention to. And this was the contract extensions that we then did responsibly in terms of switching from one provider to the other or extending contracts of the same provider in that period. And in that time, we had the ongoing relationship with SAPS to support the EMS, that's SAPS and city law enforcement and neighborhood watchers, to support EMS entry into red zones in terms of the protocol that we've observed in that time, which is the ambulance, if it's a red zone, arriving at the central point, to be accompanied by either SAPS or law enforcement, and finding its way to safe zones with the help and support of the neighborhood watchers or community policing forums in the areas. The third risk was the stockout of essential pharmaceutical goods. Again, this risk remained the same from the previous quarter. The inherent risk is extreme, impact 4, likelihood 4. The residual risk was moderate, and that was the impact was 2 and the likelihood was 2. So the tolerance level is within what we manage within the department. So the residual risk rating remained at moderate due to the following. The dues out items have increased in Q4. That's the number of items that is available at the Cape Medical Depot. And we keep a very close eye on those numbers because all our primary care facilities, together with the City of Cape Town and many of our hospitals, are dependent on pharmaceutical items that are supplied from the Cape Medical Depot. The dues out items have increased in Q4. There was a dip in supply was experienced in the latter part of Q3. So there was a supply issue in terms against the national contract that suppliers couldn't keep up with all the things. And bridging contracts were being placed. So that is when a contract expires, towards the end of a contract, the suppliers start doing necessarily the volumes that they have, and we have irregular supply. And before the new contract is approved, suppliers are not ramping up because they've not been informed whether they're successful and the ramp up. So this bridging contracts were being placed in that time. It's important to note that the residual rating is within the department's tolerance level, though, because we have a team that's working extremely hard to mitigate those risks. Although it's not fully within the control of Western Cape government, there's significant reliance on the National Department and National Treasury about the management of the national pharmaceutical tenders and contracts. But our team work with that inherent risk, and they do reallocation of stocks within the department. They do direct delivery from suppliers. We establish very good relationships with suppliers. So in a sense, our team do everything in their power to mitigate the risk in this regard. The next risk 4, is fraud. The movement was the same because the inherent risk was low. The impact is 1, the likelihood is 4. The residual is low, impact is 1, likelihood is 3, and it's within the tolerance level. The risk for fraud, corruption, and theft is rated low within our department's tolerance level, and the department considered to have a high level of control over this risk, including the support it received from the .P Provincial Forensic Services. So we have a regular interface with Provincial Forensic Services, Chairperson, and any sign of fraud or any sign of untoward behavior is thoroughly investigated internally and in very close collaboration with our relationship with Provincial Forensic Services. The primary controls such as finance, supply chain, people management, business processes, in conjunction with the controls from the various DICUs. DICUs are internal control units that specifically is internal to our organization, and they go and check in terms of checklists all the controls in a regular basis across our entire department. So this is an institutionalized practice in our department, and they're all geared towards minimizing the impact and the likelihood of fraud occurring in our department. The service delivery pressures is the highest pressure in our department. The standing committee is very familiar with that because that's our engagements over the years with this committee has very much been on the ongoing and high service delivery pressures facing the department. So the movement was the same. It was extreme inherent, 3 impact, 4 likelihood. The residual is extreme, 3 impact, 4 likelihood, and it is above the tolerance level. So the risks remain extreme throughout the 18-19 financial year. It's above the tolerance level of the department. And what we have done, and at the time, Chairperson, I was the chairperson of what is called OPEXCO. Just to explain that to you, OPEXCO is the management team in our department that constitutes all the service managers. And me as the chief of operations at the time, chairs a committee that meets every month of all the service managers, which includes the CEO for Grootskier, the CEO for Tygerberg, the CEO for Red Cross, the chief director for Metro Health Services that has most of all the Metro services under that CEO, including the psychiatric and specialized hospitals, the chief director for Rural Health Services that has all the rural services, including the regional hospitals, Paul, Worcester, and George, and then the chief director for emergency and clinical service support, and that has all the health programs, all the pharmaceutical services, and then all EMS and FPS, so the emergency medical services and forensic pathology service. So those senior managers meet together with the chief of operations once a month. Their mandate is to oversee the service mandate of the department. That team have then identified in that time 6 specific pressure points to systematically address. And what they do is we then at that time gave regular feedback to our senior management team. So this is a standing item on TEXCO because the tolerance levels is above. So it's a standing item on TEXCO at every month to year feedback on these specific issues. These 6 issues are big issues and they were systematically addressed. So it is about neonatal pressures. You need to understand neonatal pressure starts with maternity pressures. So to have a pressure of newborns, you also have to understand the pressure of the birthing service of deliveries. Mental health, a big pressure point. The pressure in all the emergency centers being overfull, especially trauma-fueled weekends. Operating theatres, that is a pressure that operating theatres are under pressure from big service loads to be processed in the operating theatres. Critical care, that is high care and ICU care, which is a big bottleneck in our system because there are scarce skills and the demand for critical care exceeds the supply for critical care on an ongoing basis in our system. And the last one was the forensic pathology service. At the time, there was an increase in a big spate in homicides, and there were a lot of bodies for post-mortem that were backing up. And at the time, very well publicized at the time, the engagement with the Muslim Judicial Council about the delays of bodies of Muslim faith in terms of these backlogs in those places. So we began engagements with all the relevant clinicians and clinical management to develop the mitigation strategies. It started firstly with the obstetrics and the neonatal service, and the learnings from this process were used to unpack the others. So just to explain to you what it means, we systematically, from a community-based worker to a primary care sister, to district hospitals, to the specialized, the regional hospitals, and the highly specialized hospitals, Groot Skeer, Tygerberg, and Red Cross. We unpack systematically the services for maternity care and for neonates, together with EMS and the transport issues, health net transport issues. And at the whole system level, we put mitigation strategies in place to unpack and to really streamline and improve the system. The way that we did it, we applied to mental health, to ECs, to operating theatres, critical care, and forensic pathology. The process has culminated in what we call deep dive sessions, Chairperson. So on a quarterly basis, at our monitoring and evaluation centers, sessions, we then get all the detailed information for these focal areas and systematically unpack our performance over the preceding quarter. What has happened to deliveries? What has happened to this? What has happened? And we have detailed engagements and presentations to actually try and mitigate from a performance perspective also these high pressure areas. The sixth risk is water shortage. It remained the same from the previous quarter. Inherent 4, likelihood 2. The impact was low. Impact is 1, likelihood 2. It's within our tolerance level. At that point, the residual risk of water supply shortage was rated low within our tolerance level. The inherent risk rating remains high due to the nature of the risk, which is water shortage. It is furthermore a risk that's not within the control of our department. But we implement controls to manage the impact on staff and patients at our facilities. So due to the critical nature of the risk, investments has been made to control the risk. So we've done tremendous water augmentation controls at every facility, water utilization benchmarks, and then actual consumption at facility level is monitored. So if you go to certain of our facilities, we can track exactly what the consumption is per unit in that facility with controls in place to actually set targets to manage it across all the places. So the engineering part has been tremendous, fixing all leaks and then having augmentation in terms of water tanks and boreholes across all our facilities. So at that point, the risk was very successfully mitigated at that point. The last risk, risk number 7, is the aging infrastructure and health technology. It remained the same from quarter 3 to quarter 4. Its inherent is extreme, because impact is 3, the likelihood is 4. The residual risk is high, impact is 2, likelihood 4. So it's also above tolerance. And this risk remained high in 1819 due to, and it's above our tolerance level. The contributing factors which most significantly contribute to this risk are the budget constraints for maintenance of infrastructure, especially aging hospitals and aging infrastructure. And therefore also the budget for replacement of aging health technology, which is all our equipment, because we are a very highly sensitive and high level equipment intense organization at the bigger institutions. And then also the escalating cost of maintenance. Significant assistance were received from the National Treasury, National Department of Health, the Western Cape Department of Transport and Public Works, and also Provincial Treasury. And it's all required to manage this risk. So we've actually did quite a lot of work to bring all of those parties together to look at the streams of funding that were made available to help us mitigate the risk, but it still remains high. So the allocations for maintenance were increased, but not nearly enough to cover all the risk that was associated across the specific risk. So this is a summary of what I've just said. So if you take each one of them, it takes you what each risk is. This is the 7 risks that I've just went through. It tells you what the inherent and the residual was in quarter 1 to quarter 2 to quarter 3 to quarter 4. You can see I've just given feedback on quarter 4 and all these arrows in terms of, so at the like, you can see one risk we actually reduced further in quarter 4, the others maintained because we've actually achieved the reductions earlier in the financial year. So just to lift out the ICT and fraud risk, because this is an additional requirement that we have to table at the audit committee. So IT and fraud risk, an update on the fraud and corruption prevention implementation plan was tabled. A fraud risk register was discussed. A formal IT risk register has been developed and was tabled at the committee. The Texco decisions. The big decision was that for services, we were managing the services as indicated. For the residual rating of maintenance, we're managing it with all the departments. The one area is the societal violence. And we at that point then noted that violence was already on the Western Cape government provincial risk and receiving wider attention, which subsequently would become the Western Cape safety plan. But at that point, we were part of a broader Western Cape government issue around violence and safety. Thank you, Chairperson.
Thank you very much for the presentation, Dr. Kluter. Is there anyone else from the department that will present? In the absence, I will ask Minister Mbombo if there is anything that she would like to add at this stage.
No, Chair. As I already indicated, that we are talking about the requirements of the 2 years ago, which we, as the HOD has implemented. Now it's for the application or implementation in the last year financial year, which is currently being audited. Thanks.
Thank you very much, Minister. Members, then I need to just remind you on what this meeting emanates from, and that we please keep our questions accordingly. Members, by a show of hands, I will now grant you the opportunity. Any questions from any members? Member Windvogel, you may proceed.
Thank you, Chair. Chair, mine is on slide 4. I just want to understand what does a low and within tolerance levels mean? And how can we link this to the department's complaints of inequitable sales that is always decreasing each year?
Did the department get the question? There was a bit of a breakup.
Yes, no, I got the question, Chairperson, I got the question.
Thank you, Dr. Kluter. I now recognize Member Barnes.
Thank you, Chair. My question is on the mitigation strategies. If it will be possible for the committee to be furnished with a mitigation strategies document. Also on slide 7, my question would be, why is the risk as low as it's displayed there? Were all of these controls used to prevent corruption during PPE procurement, or why is it so low? If I can just get the answer on that. Thank you, Chair.
Thank you, Member Barnes. I don't see any other hand function. Is there any other member that wishes to pose a question? Not. I will now afford the department or the minister to kindly respond.
I'll ask the HOD to respond, but again, to reiterate what we indicated, that this is all based on the 2018, 2019. And even last year, the issue about the PPE, it was not even a surface, it's only for this year. Thank you, Chair.
Thank you, Chairperson. On Member Windvogel's question, on slide 4, just to explain why the residual rating, which is impact 1 and likelihood 2, is low and is within tolerance. The question here is, what are we doing about the fact that the money that we get is not enough to cover all the services? So the issue is, we have mitigation strategies in place so that we do not overspend. That's the issue. So it's not that we have enough money to cover all our service risk. That's why the service risk risk is so high, and it remains high, because we do not have enough money to respond to all the service issues that comes in. But for this specific one, the issue is, you are given a limited budget. What is the risk of you overspending your budget? And we have proven year after year that we don't overspend our budget. And in fact, in this year, at the end of that year, we actually underspent by 56 million, but it was mainly because money was added for filling of posts late in the year, that with the recruitment selection was not sufficiently filled by the time the financial year closed at the end of March. So that is to explain the comment that asked by Member Windvogel. If I go to Member Barnes, so when she says mitigation strategies, I just want to be clear that for each one of these, there is mitigation strategies that we have for each one of the 7, and they are explained in the comments. We have risk committee meetings, we have documented minutes, and we have discussions of the risk committee of all these mitigation strategies that we keep. But if I go to slide number 7, then it is the question in slide number 7 of fraud. Now, the issue here is that our inherent risk is low. So the likelihood is 4, the impact is 1. The residual risk is impact 1, likelihood 3, and that's within our tolerance level. And the reason why our inherent risk for fraud is low is because of all the controls we have in place. Now, the controls we have in place is systematic, it is detailed, and it is controls that is called, there's an internal assessment process, there is a compliance measurement instrument, and we do it with these DICUs that I just said. It's teams that goes and they check every payment once a month. They go and they check across all the departments, all entities. They take payment packets and they see whether all the processes were followed. Was there a valid contract? Was the tender done? Was the thing fairly done? Did members disclose their interests? So all of those controls is systematized through our entire organization. As because of those controls, that the risk for fraud is extremely low, and that is also backed up by the instances of where people are potentially reporting fraud and what is being investigated to actually find proven fraud in our department. It is extremely low. And even though this has got nothing to do with PPE, because PPE is happening in 2021, that is the reason why we are actually an organization that inherently have sufficient controls to mitigate and buffer us against any potential risk. Thank you very much, Chairperson.
Thank you very much, Dr. Klute. Can I ask members Windvogel and Barnes to kindly lower their hands? I will now afford an opportunity to Member Tego. Please proceed.
Yeah, thanks, Chairperson. Mine is on slide 9, the water shortages. If I check the presentation correct, it says the inherent risk rating remains high due to the nature of the risk. And it is furthermore a risk that is not within the control of the department. understanding that we had a situation of drought and all that, I just want to have clarity in that regard. Was it because of infrastructure shortages, or is it because of, we're talking about drought challenges that resulted in those facilities having a challenge of water, of which it is expected that health facilities are supposed to deliver better. And then on slide 10, the issue also that goes to the aging infrastructure in terms of health technology. Here it says that allocations for maintenance were increased. Now, what I want to understand is, as far as that has this been addressed since the increase, or it still remains because of outstanding, because we can in terms of the current state of affairs, what is the situation right now that there was an increase in terms of allocation, but was the problem itself, the risk itself, mitigated? Thank you very much.
Thank you, Member Keho. That covers your questions. Any other member at this point wanting to pose a question?
Chairperson? Chairperson?
Yes, Member Mvumbi.
Yes, Chairperson. It's not necessarily related to the question we really came here for. Needless to say that one has been addressed. I'm quite fairly happy in the manner in which it has been addressed. But while I'm here, obviously, I've just noticed or pick up on the issue of what really ignited my interest is on the issue of the aging infrastructure. While, you know, Chairperson, you can afford to have an aging infrastructure in some areas like roads and so on, but when it comes to health, I don't think we really want to take a risk of having to have aging infrastructure on health-related issues. Just want to check whether this infrastructure, is it buildings or is it equipment? And then maybe also, and how is it actually being actually addressed? That's just something that really ignited my interest.
Thank you very much, Member Mvumbi. I will again caution members to please let me deal with the matter at hand and the purpose of today's meeting. Member Mvumbi, we will gladly as a committee deal with your comment or your concern or your question with regarding to infrastructure at the end of the meeting. Concerning to our recommendation and resolution, I think we can then ask the department for a thorough report and then deal with it accordingly. Any other member? Nothing. Members, that now concludes then our round of questions to the department. I will now afford them an opportunity to respond to, after which we will then excuse them and deal with our meeting documents. Please proceed.
May I proceed, Minister?
No, I think they're all technical, and you can answer that. Thanks.
Thanks, Minister. Thanks, Chairperson. Thank you for the questions. So if I go to slide 9 and the issue about the drought challenge, it is right, the member is right. As a department, we have put in place boreholes, we've put in place water tanks, we fixed all pipes. So in terms of what we were mitigating is we were at that point able to mitigate water supply to the institution because we've maximized what we can do with the supply we get. The remaining challenge was the drought, whether we are getting sufficient supply. But we were also supplementing it at the time with borehole water in terms of that. So that's why we were able to mitigate the challenge. Although the big challenge that he's asking is actually the issue of drought. So it's the rainfalls and the drought that was the issue. Thank you for that question. Then slide 10 is the maintenance mitigated. So I did say that we did get some money, but the point I made is the scale of the maintenance backlogs, and it's both for buildings and it is for equipment, is of such a nature, whatever we got was not sufficient to mitigate the full risk altogether. And that is the long and short, because the question was it mitigated? So I would say it was partially mitigated, not fully mitigated. And it was mainly mitigated about the single biggest risk in terms of aging infrastructure and equipment, which was Tygerberg Hospital. But that's not the only place in the department where there's aging infrastructure and technology. Thank you, Chairperson.
Thank you very much, HOD. Any closing remarks from your side, Minister Mbombo?
Thank you, Chair. I think, as I indicated earlier, Chair, that it will be useful probably to bring some of these when we are presenting the 2019-2020, just to check whether indeed we have implemented them. Because as I indicated, that now we are relying on what we are presenting, but there is no evidence. And yet, when now we have the for the report for the 2019-20, that's when you can compare and say that that's what you said you did. Look at this page now in this report. Actually, we didn't do much. It will also be even to respond to some of the questions. For example, when we say that the water is is a low risk in terms of the tolerance, and then we find that probably there might have been 5 or 4 of the facilities where there was no water, not because of the day zero, but probably maybe the piping system. Just making an example, in Tygerberg, there was some time long ago where you'll find that because of the plumbing, because of the old infrastructure, it resulted there on a few hours where there was no water. But thank you again. See you in the next one, the next committee in the afternoon. Thanks.
Thank you very much, Minister, for your time. Thank you very much, HOD and your staff, for the response and the clarity provided. We do appreciate that as a department. If there's anything emanating from this engagement, we will communicate with the department as such. You are now excused. Thank you very much.
Thank you. Thank you, Chairperson.
Members, thank you very much. Is there any recommendations or resolutions emanating from today's meeting from your side?
Yes, Chair.
Member Van Vogel, is that you?
Yes, Chairperson.
Please
Chairperson,
proceed, member.
Yeah, Chairperson, mine is also on the infrastructure. I think we need to get maybe a report on all this, a report on the infrastructure. I think you just indicate to Member Mvimbi that will be part of our, what you call it, resolutions. So for me, it's important that we understand how far did we get with the Jewish Hospital, all the infrastructures in the Western Cape, especially the Jewish Hospital, and that's one of my concerns. I think I will park there, Chair.
That's duly noted. Thank you, Member Van Vogel. Any other member? Nothing. Thank you, members. We will now then proceed to our meeting document of the 12th of August. Ms. Jamke, can you please put up the document for us? Member Makamba Botya.
I've got my hand raised. Sorry, I'm sure you missed that out.
You are recognized, member.
Okay, Chairperson, good morning. Thanks for having me. Chair, I just want to find out if the department is able to give us the status of the infrastructure of Tygerberg Hospital to have such information.
Thank you very much, Member Makamba Bocha. And Ms. Jamke is online. She can just correct me if I'm wrong. I believe in the next committee engagement, we do have Tygerberg Hospital tabled as an item, specifically in terms of infrastructure. But I think the point made of infrastructure in totality will definitely also cover the facility, as you have mentioned, member. Thank you very much, Member Barnes. Is that an old hand?
No, it's a new hand, Chair.
Okay, please proceed, member.
I've asked for mitigation strategies. I think I've written on even on the chat because I think I'm not clearly vocal on the it's actually on slide 8, so I wanted to check on that if we are getting my copies.
We have captured your comment. Thank you, member. Any other member? Nothing. Ms. Jamke, can we please deal with the meeting document for adoption? Is Ms. Jamke on? Mr. Daza?
Yes, Chair. I don't have documents with me. I'm gonna check with Miss Jamde. Where is she? If she's gonna.
Can you see, Chair?
Oh, there
Yes,
she is.
thank you, Ms. Jamke. We can see the document.
Yes.
Minutes of proceedings of the Standing Committee on Health, dated the 12th of August 2020. Members, kindly check your attendance. I think we can move down. Any additions or rectifications, members, please indicate.
Chairperson.
Member Botha, please proceed.
Thank you very much. On page 4, under 6 resolutions, there is a line that says the aim of this engagement would be to address all concerns and challenges, and it should be all concerns, not concern, all concerns and challenges raised by stakeholders and the department. Now that resolution, in regard to the public input number 4, it does not give a reflection. The public input number 4 does not give a clear reflection on what the concerns and challenges is that were raised by the stakeholders. I just want to request for my own clarity, or for me to just to get to what was the concerns, to request the recording, please, of that standing committee meeting. I was absent that day. Thank you.
Thank you, Member Botha. Ms. Jamke, I'm sure we will be able to provide.
Yes, Chair.
Thank you so much. Any other member, any additions, any additional requests with regards to? Nothing, members. Can we move for adoption, please, with the necessary amendments made in terms of point 6? Sorry. Yeah. A mover for adoption, members?
I move, Chair. Member
Thank you,
Van Vogel.
Thank you, Member Van Vogel. Second. Members present at the meeting that wishes to second the minutes?
Seconded by me, Member Chairperson. Thank you.
Thank you very much, Member Allen. Members, I believe that concludes our committee engagement this morning. I wish to thank you very much for your time and your effort and for your input as well. Therefore, I now adjourn this meeting and wish you a blessed day ahead. Thank you very much.
Thank you, Chair. A blessed day for you too, colleagues.
Thank you.
Thank you,
Goodbye.
Chairperson. Thank you, Chairperson.
Thank you. Bye.